Okay, well, welcome everyone. There's plenty of seats up here for those who are just coming in, want to grab lunch and come up front. Everyone's favorite seat. So thank you so much for joining us today for our second Rare Disease Congressional Caucus briefing of the year. I am Jamie Sullivan. I'm the Senior Vice President of Policy and Advocacy with the Every Life Foundation for Rare Diseases. We're really honored to be joined today by all of you, congressional staff, advocates, stakeholders from across the rare disease community, here in the room and online for this important conversation about the access issues facing the 30 million Americans living with rare diseases and their families, friends, and caregivers. Before we begin, I want to extend our gratitude to the co-chairs of the Rare Disease Caucus, Representatives Gus Bilirakis and Doris Matsui, and Senators Amy Klobuchar and Roger Wicker. Their leadership and commitment to bicameral and bipartisan action on issues ranging from improving the diagnostic odyssey, addressing regulatory innovation, and as we're going to talk about here today, solving for the access challenges facing the rare disease community really exemplifies the best of what Congress can do to improve the health and well-being of our country. So today's briefing is focused on the topic of access, but access to care isn't just a single issue, as you'll hear from our speakers today. Access to care and treatments is often shaped by a patchwork of policies that often aren't designed with rare diseases in mind. So for many patients, access to care may mean access to home and community-based services that allow them to remain independent and connected to their families and communities. For others, access means ensuring that insurance practices, such as step therapy, do not force patients to fail treatments that are inappropriate for their disease before they can access the therapy their clinician believes is best for them. For others, it means access includes ensuring the continuation of telehealth flexibilities that have become essential for patients who may travel hours to reach the right expertise that aren't in their own state or local area. It may also mean ensuring patients and families have access to genetic counselors or other experts who can help them understand the complex diagnoses and make informed decisions. And lastly, for some individuals with rare diseases, medical foods and specialized formulas are not optional conveniences, as you'll hear today. They're essential components of medical care. And we cannot talk about access without talking about caregivers. So today you'll hear the important role that caregivers play in supporting the healthcare system. They coordinate appointments, administer treatments, manage complex medical needs, navigate insurance, provide transportation, and countless other services they provide the rare disease loved ones that they care for. Yet, the financial, emotional, and physical toll of caregiving is often left out of discussions about healthcare access. We're not going to do that here today. The issues we'll discuss are different, but they share a common theme, that a treatment or medical intervention only improves a person's life if they can actually access it, and if the people supporting them have the resources to make that access possible. The issues you'll hear about today are a mere sampling of the myriad access issues facing the rare disease community. Others, such as foundational challenges like the lack of ICD diagnosis codes for close to 97% of the 10,000 plus rare diseases, or the growing challenges with prior authorization, or in rare disease restrictive coverage criteria, or as you'll also hear about today, preserving access to Medicaid coverage. We cannot forget all of these challenges, but today we're going to hear from 5 great speakers about a sampling of those challenges. The policy solutions you'll also hear about are practical and achievable. They're about removing barriers that prevent patients from receiving appropriate care, supporting caregivers who make that care possible, and ensuring our healthcare system works for people whose needs don't always fit into our traditional models. With that, let's introduce our panelists and hear about the policy issues they want to talk to you about today. So first, we have Maynard Freeze, who is and I should have their title, he leads government affairs for the Cure SMA. We have Shannon Wood, who is Director of Disability Policy for the Muscular Dystrophy Association. We have Jason Harris, who is SVP for Access and Advocacy for the National Psoriasis Foundation. And we have Sarah Chamberlain, who is the Founder and Chief Program Officer with Flock Health, as well as Carolyn Applegate, who is a genetic counselor and an assistant professor for Johns Hopkins University. So we have just an incredible all-star lineup of panelists. Their bios are available on the back of the agenda document, so we're not going to read them all, but they all are immensely accomplished individuals, and I'm really looking forward to hearing what they have to say. So with that, I'm going to turn it over to Maynard.
All right. Well, hello, everybody. So before I begin, let me just say one of my bucket list things was to speak to a standing room only audience, and thank you very much. Now, I won't tell everybody it was a really small room, but in my story, it will be much, much bigger. So again, my name is Maynard Fries, and I work for Cure SMA. Cure SMA is the leading national organization that represents children and adults with a rare disease known as spinal muscular atrophy, or SMA. SMA is a neuromuscular disease, and it impacts the muscles used for everyday living activities such as coughing, breathing, walking, and other movements. SMA impacts individuals and children and adults in all 50 states. This is a list of who we are in your communities and in your states. So SMA is a neuromuscular disease and affects physical abilities, but it does not affect cognitive or other abilities. And so our folks are top of class in high school and in college. They are active in all parts of the economy, active in their community, volunteering and participating. They are moms and dads, their fathers, their sons and daughters, their aunts and uncles, their grandparents, and they're your neighbors. All those great things are only possible because of caregivers. As this adult with SMA said, without caregivers and caregiving hours, I would not be able to live independently, be successfully employed, or enjoy anything fun as I would be stuck in bed. All because without caregivers, none of that is possible. SMA is a medically complex disease. It worsens over time. And so people's needs don't change. They maintain or even increase over time. And they require the needs of a caregiver to be able to do daily functions such as dressing and grooming and bathroom support, as well as complex activities such as respiratory support and nutrition assistance. To help illustrate this, I have a quote here from a 26-year-old with SMA. He's a college graduate and is in software engineering. Because of his SMA, he doesn't have strong chest muscles. And as a result, he cannot clear his mucus from his lungs the way most people do. He says that if it's not cleared, it settles and can quickly turn into pneumonia, something that he was hospitalized for repeatedly as a child before he had consistent, well-trained caregivers. He goes on to say, clearing my airways requires a precise manual cough assist technique. A caregiver applies pressure to my chest in exactly the right place, with exactly the right amount of force. Too little and it does nothing. Too much or in the wrong spot and it can injure me. I actually spoke with him by Zoom just a couple weeks ago, and his caregiver demonstrated this technique, and I will say it is very complex, and it would be something that I would not want to do without lots and lots of training. So people with SMA and others are able to access caregiving through Medicaid. Medicaid, as you know, is the primary payer of long-term services and supports. And because of bipartisan legislation back in the 80s, signed into law by President Reagan, Medicaid is allowed to provide institutional level care in the home and in the community. Now, this is where folks want to receive their care anyways, but it's also been effective in terms of health outcomes, and it's also certainly cost effective as well. Because of access to Medicaid caregiving, our folks are thriving. People with disabilities, people with rare diseases, people with SMA. They're thriving in the school place, they're thriving in employment, and they're thriving in the community. I won't read these, but you can see some of the quotes from adults with SMAs all across the country and how Medicaid caregiving provides them the opportunity to maintain their health, live independently, and participate in their community. Despite the fact that Medicaid caregiving is essential, it's vital to the day-to-day life of people with SMA and other rare diseases, and that the proof is that it increases health outcomes and it's cost effective, our folks continuously struggle to access Medicaid caregiving. As this slide highlights, we surveyed the SMA community. Our folks struggle to find caregivers to fill the caregiving hours that they have. And when they have a caregiver, they struggle to retain those caregivers, particularly those that are reliable and those that are trained. Most difficult, as it says here, is the nights and weekends. Just because they don't have a caregiver at night and weekend doesn't mean that that need doesn't go away. In addition, oftentimes our folks don't receive the caregiving hours that they really need to truly be independent through the caregiving hours from their state. More recently, we have been under threat and pressures based on budgetary issues at the state level and at the federal level, particularly related to the implementation of H.R. 1. And then more recently, we believe there's a lot of misunderstanding or lack of understanding about what the vital nature of caregiving really is. As I mentioned, for people with SMA and other rare diseases, caregiving is essential to health and independence. It's not optional. It's not wasteful. It's also skilled and complex, as I shared with that example of the cough assist. It's not simply companionship or conversation. And then we believe that caregiving is not a one-size-fits-all solution. It has to be tailored to the individualized needs. If you have two people with SMA, their needs are very different based on their personal lifestyle and based on their severity of the disease. And we believe policy needs to recognize one-size-fits-all is not the way to go for caregiving. I want to demonstrate why caregiving, Medicaid caregiving, is really a lifeline for people with SMA, and it's not and shouldn't be considered a budget line. It's this case study of a 38-year-old adult with SMA. As you can see, he lives independently, participates in his community, even serving on a national board, and he works full-time. He accesses 42 hours of caregiving a week. Now, that may seem like a lot. That's a work week, right? We all work around 40 hours a week. But when you think about it, it's only 6 hours a day. He gets 3 hours of caregiving in the morning, which allows him to get out of bed and into his power wheelchair, go to the bathroom, eat, shower, get dressed, and then positioned into his workstation. Then he's alone from 9 o'clock until 6 o'clock, meaning that during the workday, he literally minimizes what he eats and minimizes what he drinks because he doesn't have the support during the day. Then he has a caregiver who comes in the evening, and that caregiver then gets him back into his power wheelchair, get him fed, get him to the bathroom, do some errands, and then prepare him for nighttime. And as you see, between 9 and 6, he's alone again. I just want to highlight where the risks are in his current schedule at 42 hours a week. He's alone between 9 and 6 in the afternoon. He's alone between 9 p.m. and 6 a.m. Now, he doesn't have the physical ability to be able to reposition himself. That can cause pressure sores. He doesn't have the ability to get something to drink in the middle of the night or go to the bathroom. That can cause dehydration and cause urinary tract infection. This is what his current schedule is. And if there is policies that happen at the federal or the state level that somehow impacts his ability to get those 42 hours, even by a half hour, what are you going to cut from his schedule? Do you skip the bathroom break in the evening? No food in the morning? I mean, that's really what's at stake for people with SMA. And that's why really our mantra is we can't have Medicaid be a pay-for reconciliation or for any other future legislation. The stakes are just too high for people with SMA. Now, we understand that the intention is not to cut caregiving for people with disabilities and people with rare diseases like SMA. That said, we also understand that the ripple effect at the state level can oftentimes lead to cuts in eligibility or cuts in care to the very people that we want the program to be for. In addition, we ask that you continue to maintain, protect, and strengthen existing Medicaid home care options, particularly related to self-directed care, This is where an individual with SMA and others can pinpoint exactly when throughout their day they can get that caregiving services so that there isn't big gaps throughout the day. And in addition, while this isn't something that all of our folks use, it's really more rare, paid family caregiving. It's a vital option for those who require it, particularly for rural areas where the pool of caregivers just isn't there. And so having a paid family caregiver is the only option sometimes. Also, SMA gave the example of weak chest muscles. A simple cold can lead to several days of hospitalization for a person with SMA. So having caregivers rotate in and out of the house is really not safe for those individuals. Paid family caregiving allows more health for that person and minimizes hospitalization, which is a cost saver for the entire system. This is actually my last slide. I wanted to close here with a quote from an adult with SMA. They said, "Every day, every action, every dream, every simple task is blurred by SMA." I highlight that just to highlight the fact that SMA is really a devastating condition. It's a medically complex condition, and our folks have challenges that they have throughout their daytime. That said, because of medical equipment such as power wheelchairs, and because of access to caregivers, they're able to do great things, all the great things I highlighted in an earlier slide. My ask of you, all of you who are working in policy, is consider the impact that your changes could make on a person with SMA. Our hope is that public policy isn't just one more thing that blurs or impedes or restricts their ability to take action, to dream, and to take simple tasks. Thank you very much, and I'll turn it over back to Jamie.
Wonderful. Thanks so much, Maynard. So we've heard a lot now about the important role that caregivers and home care play. Now I invite Shannon to tell us a little bit about some of the policy solutions that make sure that caregivers have some support.
Thank you. Sorry, I'm a little short for this podium. My name is Shannon Wood. I'm Director of Disability Policy at the Muscular Dystrophy Association. And today I'll be speaking about policies to support family caregivers. So first, a little bit about MDA. MDA serves people living with muscular dystrophy, ALS, and related neuromuscular diseases, including SMA. For over 75 years, MDA has led the way in accelerating research, advancing care, and advocating for families. For those who are not familiar with neuromuscular disease, although I know you just heard quite a bit from Maynard, they are rare and genetic. Most are caused by changes in at least one gene, and they can present at birth or later in life in adulthood. And generally, they cause muscle weakness, fatigue, and are progressive, meaning that they get worse over time. And MDA's mission is to empower the people we serve to live longer, more independent lives. So looking at caregiving in the neuromuscular community, we know that research breakthroughs are leading to longer lives for so many conditions under MDA's umbrella, but due to their progressive nature, many will require support at some point in their journey. And as Maynard said, family caregivers really serve as the backbone of the neuromuscular care system. They fill gaps left by insurance and really complete these essential specialized care tasks, whether it's helping with complex medical arrangements, assisting with mobility, providing emotional support, financial help, and more. The bottom line is that family caregivers improve quality of life and prevent unnecessary, costly, harmful institutionalization, keeping people in their communities where they overwhelmingly prefer to be. And while it can be deeply rewarding, speaking from personal experience, caregiving can also present significant challenges. And a top challenge that is shared with MDA's Resource Center is difficulty navigating the government agencies to get the benefits that their loved ones need, whether it's health insurance like Medicaid or Medicare, or Social Security benefits like SSI or SSDI. They're constantly telling MDA about how they experience what we refer to as administrative burdens. So frustrating, invasive, repetitive paperwork, waiting for hours to speak to someone, really complicated applications and websites, and all of these really serve as barriers to care and coverage. Thankfully, there are leaders in Congress who have introduced legislation to reduce administrative burdens, and that's through the Alleviating Barriers for Caregivers Act, or the ABC Act. The Senate bill number is 1227, the House bill number is 2491, and again, this is bipartisan and bicameral, and let's take a look at what the bill does. So this bill requires CMS, the Centers for Medicaid and Medicare Services, and SSA, the Social Security Administration, to review their eligibility processes, procedures, forms, and communications to reduce burdens on family caregivers and individuals navigating benefits. There are some specific goals that are outlined in the legislation for the review. The first being to streamline policies and simplify procedures to determine your eligibility, enroll and maintain coverage, and utilize the full benefits that are available to you. The second goal of the review is to reduce the frequency of providing the same information more than once, whether it's completing multiple documents for each agency or providing information they could easily get from another agency. So think about things like medical records and work history. Another goal of the review is to make it easier for family caregivers to work with agencies through very specific measures outlined in the bill, like decreasing call wait times, providing timely answers, improving the accessibility of their websites, improving access to in-person appointments, and also just generally improving relationships, like through regular meetings. The really important thing that we love about this bill is that in conducting the review, officials must seek input from family caregivers, including caregivers with disabilities, as well as individuals who are filing for or receiving benefits on their own. A report to Congress is due no later than 2 years after the review. That's to be publicly posted on agency websites, and that will outline the issues that they identified, actions being taken, and recommendations for changes to the law. So the congressional ask before you on the ABC Ask is to co-sponsor the bipartisan ABC Act. It has been, again, introduced in the House and Senate. On the House side, it's been jointly referred to Ways and Means and Energy and Commerce Committees. On the Senate side, it's been referred to Senate Finance. And then another top challenge that we hear over and over again from family caregivers in the neuromuscular disease community is difficulty covering the high costs of caregiving. Neuromuscular care is very expensive, it's very complex, and it requires lifelong management. Some of the top costs for the neuromuscular disease community can include medications and specialist visits, assistive devices and technology, home and vehicle modifications to make their home and vehicles more accessible, and of course, paid care. And the neuromuscular disease community is really not an outlier here. The most recent data from AARP estimates that family caregivers are providing about $600 billion annually in unpaid labor, that they're spending 26% of their income on caregiving expenses out of pocket. That's about $7,200 a year. And really concerning is that nearly half, 47% of family caregivers report at least one negative financial impact as a result of providing care, whether that's stopping putting money towards their savings, taking on debt, or leaving bills unpaid, or putting bills on credit cards. But again, we have leaders in Congress who have introduced legislation to offset certain costs of caregiving, and that's through the Bipartisan Credit for Caring Act. The Senate bill number is 925. The House bill number is 2036. And this bill is very straightforward. It would create a 30% tax credit on qualified expenses after an initial $2,000 in qualified expenses is spent, up to a maximum credit of $5,000. It does phase out at higher incomes and coordinates with existing provisions to prevent double dipping. And the great thing about this bill is that a lot of the qualifying expenses included in the legislation include really core components of neuromuscular disease care. So home health aides, home modifications, transportation, assistive technology, adult day services, respite, so that the caregivers can receive a break from their responsibilities. The caregiver must have more than $7,500 in earned income a year, so this is really a policy solution geared at working family caregivers. The ask here is that we are asking both senators and representatives to offset the high cost of caregiving by co-sponsoring the Bipartisan Credit for Caring Act. Again, it's been introduced in both the House and Senate and is awaiting committee action. There are a ton of bipartisan co-sponsors on this bill. On the House side, it's been referred to Ways and Means Committee, and on the Senate side, it's been referred to Senate Finance. Thank you, and I hope your bosses can support these great bills.
So now we're going to pivot a little bit away from caregiving to an equally important issue of accessing the right treatments for that your physician or healthcare provider has determined are best for you. And Jason, would you tell us a little bit about step therapy?
Thank you. Thank you, Jamie. Thanks everyone for being here. Appreciate the invitation from Every Life. I have no slides today, so I'll probably be slightly quicker, but hopefully everyone can stay with me and not look at my face there too much. So I'm here representing both the National Psoriasis Foundation and also a coalition called the Safe Step Ad Hoc Coalition. I don't know if folks have heard that before. I'm seeing some head nods. And so what we're here to talk to you about today is step therapy reform, or the Safe Step Act, how many folks are like familiar with step therapy or even that bill at all? It's decent. Okay. At our recent Hill Day, we asked everyone if they've been through step therapy, about 75 people, and probably 80 to 90% of the room raised their hands, which is not really unique. It's a pretty common practice that we can get into in a little bit. But I'm going to first start out with a story of sort of when step therapy can go wrong. And this comes from an individual in our community. She came to our most recent Hill Day and shared this experience where she was about 19, 20 years old. She was really trying to understand what was going wrong. Her skin was starting to present in different ways due to the inflammation of psoriasis. However, she couldn't get in to see a dermatologist. And then when she did, there was months of sort of back and forth on what this is, what this isn't. And eventually, after about 6 to 9 months, she got a diagnosis. The physician immediately knew, like, this is going to be the best therapy for you. Went to fill it, couldn't get it, was told, hey, you're going to have to try a different treatment, one that actually was first in line at the time, but has really dangerous impacts to her ability to childbirth. And so she's sitting here at about 20 years old, having to make this decision of, like, do I go with this treatment where I'm being told that I have to sign this form that says I acknowledge that I may, something may go wrong down the line if I want to choose to have children? And she decided, okay, you know what, my disease is too much out of control, I'm going to do it. Went through it, didn't really work. Eventually, months later, she was able to get on therapy after kind of going through some of the process, but she changed jobs and a couple years later, and then had to go through this process again, right? And so for her in this situation, her disease got worse over these months of trying to figure out, can I get to the therapy I want? Then B, she was able to get on the therapy that the doctor knew would work, but then she changed insurance plans and had to go through this like odyssey once more. And eventually, in our community, for biologics in particular, or a lot of systemic treatments, if you take it and then stop and then try to get back on later, it's not necessarily going to work again. So it's not as simple as just trying to say, like, oh, well, you can just take it now, here and then. And that's just an example from our community. There are, unfortunately, countless examples of when inappropriate use of this practice can sort of lead to worse health, which is obviously not the goal we all have. And so what this bill does, the Safe Step Act, it's HR 5509 S2903, 150 plus co-sponsors in the House, almost half of the Senate here. So it is widely supported, very bipartisan, has been around for many Congresses. Our coalition is 200 plus patient, healthcare professional, physician, provider organizations that continue to lead the charge on trying to get that reform. I would shout out both Senator Murkowski, who's been a constant champion for this bill over the years, as well as Senator Hassan from Hampshire. In the House, it's two Georgia folks, Congressman Rick Allen and Congresswoman Lucy McBeth. But what does the bill actually do? The bill provides exceptions, so it puts guardrails around the practice of step therapy. Not trying to ban it, because there are uses within the paradigm that make sense, but when it's inappropriate, here are the exceptions sort of that we would lay out. A, if the prescribed treatment's going to do any harm, you don't have to take it. B, if you've already tried and failed it before, you don't need to do it again, which makes a lot, like, that's really common sense here, but that is something that continues to happen. And then C, if it's contraindicated, right, like if there's whatever's going on, you're not going to be able to take it there. And then an exceptions process of 24 to 72 hours. 72 hours generally, 24 hours if someone's life is at risk. So I would argue these are pretty, like, reasonable things to ask for. And We've seen that within the co-sponsor support over the years. What happened last Congress, it made it out of the Senate Help Committee within the PBM package. And I guess I will end with over 80% of this country has passed reform on a state level on this topic. Relatively speaking, there's slightly different provisions in each bill, but generally speaking, all the same. And I think that shows you like there is enough support. The problem or the reason we need this federal bill is by and large, most Americans get their insurance from their employer, and those state level bills do not impact the regulations for an employer's insurance. It's called ERISA. So with that, I'll end early, I think. Is that okay?
Yeah.
And all right, thank you.
Thanks so much, Jason. So now I'd invite Sarah. We're going to move from an overall utilization management challenge to hear a little bit about just coverage challenges for medical foods and formulas.
Thanks, Jamie and Shannon and everyone from EveryLife, and certainly all the members of the caucus and the staffers here today. I am going to talk about improving access to care and treatments through the lens of medical foods, medical nutrition. We referenced my titles. I work for Flock Health, which serves those with inborn errors of protein metabolism. But before I did that work, I was mom to Isabel. And you see her here. She's going to be 13 next month. I took this picture about 5 seconds before I picked up the phone and listened to my voicemail saying that she'd been flagged on newborn screening for PKU. And so this is my pre-advocacy picture, and thus begun my long journey for advocacy in medical nutrition. You can't tell from this photo, but my hair was brown then. And so the first question everyone asks is, well, what is medical nutrition? I don't get it. And that's fair. So medical nutrition is not groceries. It is not, low protein. It is not gluten-free bread. It is not dairy-free milk. It is not vegetables. These are specially designed medical products defined under the Orphan Drug Act as medically required nutrition. And that makes it a little hard to get reimbursement on them because they're in this special category. But for a set of conditions, which I'll talk about, they're the baseline of care and often the only treatment for these conditions, including inborn errors of metabolism. That first month, day 7, when we started Izzy on formula, we were looking at a cost of $1,800 a month, and for adults that can exceed $5,000 a month. That's lifelong. Medical foods, like that low-protein pasta you see there, they're often 5 to 10 times the cost of standard groceries, and they're only available by special order. So that is the practical definition of medical nutrition. The statutory definition is very strict, and that's an important thing to understand about the bill I'm going to talk about. It's furnished on order of a physician. It's specially formulated and processed for oral intake or tube feeding. It's for people who can't ingest, digest, absorb, or metabolize ordinary food. They need this to survive. And it's used under medical care and for a patient undergoing active medical care. So it's not a sort of set it and forget it. The population that the bill I'm talking about, which is the Access to Medical Foods and Formulas Access Act, the population it serves are 2 different groups. One is inherited metabolic disorders on the RUSP, so those caught on newborn screening. The reason they're on newborn screening is because they are acute, they need immediate treatment, and we have a treatment, and that treatment is medical nutrition. So we're looking at amino acid disorders, and I'm not going to read the whole list there, but all of those are on the RUSP for a reason. They're often very small patient communities. PKU is the biggest one of those. And there's about 250, 275 babies born a year with PKU. They are using the treatments lifelong. This bill also covers those with digestive and GI conditions. Those include short bowel syndrome or food protein allergies, or more common conditions like Crohn's and colitis. It's important to know that while these are relatively larger patient communities, there's usually temporary or intermittent use. It might be to get someone into a healthy state or a healthy weight where they can accept a pharmacologic or biologic treatment, or even to get a baby to a certain weight where they can have a life-saving liver transplant, for example. This beautiful quilt This patchwork is provided by NORD. Overall, they give our country a C for medical foods coverage. And while it is lovely in all these pretty colors, I would argue the reality looks like this, because even those states that have coverage, that have state mandates for medical nutrition, insurers can deny coverage based on what condition you have. So PKU is written into the bill, but a lot of others aren't. Age, gender, insurance type, and delivery method. And in that case, I'm not talking FedEx, UPS, I'm talking about how it is consumed. A lot of insurers will only cover formulas if they're delivered via a G-tube. And so you're exposing an individual to surgery, ongoing maintenance, not to mention the cost, just to get approval of that formula. And people do it. They have to do it because they need these formulas and medical foods to survive. We also have people moving from state to state or not moving from state to state because they can't lose their coverage. Getting divorced because then they qualify for different plans. It's really incredibly destabilizing to these really rare communities. So the Medical Foods and Formulas Access Act, 5684 in the House, 3304 in the Senate, provides a federal floor of coverage. It says we understand that these are required medical nutrition and our public health programs, fourth one, should cover it. This bill existed in many prior Congresses, at least 6 in my experience, but going back 20 and 30 years. The last few, it was known as the Medical Nutrition Equity Act, and it did cover private insurance at that time in that bill as well. This bill is different because it is just the public programs, but it does contain sense of Congress language that all health plans, including private health plans, should provide coverage of and access to medically necessary food, and that's defined as both those foods and formulas. There's nothing new here. Congress has already said yes to this. The 2016 Defense Reauthorization put this into law for military families in TRICARE. In 2023, a member of the PKU community advocated for the federal employee benefit plans to cover metabolic formula. It does not cover medical foods for that community, and again, that's just the IMDs. It doesn't cover GI. After the 2022 formula crisis, which hit the metabolic community incredibly hard, the Consolidated Appropriations Act recognized these medical foods and formulas as critical foods that we needed to protect as a country. And so this bill, the Medical Foods and Formula Access Act, just takes all of that and extends it to the rest of the population on public health care. We're incredibly grateful and lucky for bipartisan bicameral support through several iterations of this bill. You can see the committee referrals there. Obviously, these are the bill leads and original co-sponsors, but we do have a significant list in both the House and Senate. The community is behind this bill. We don't have 250 organizations, but we've got at least 50. And that's ranging from the American Academy of Pediatrics, NASFGAN, who has done a ton of work on this bill, Children's National here in DC, and then a bunch of disease-specific organizations who see this as the best solution for care for their communities. There is, so the ask here is to take back to your offices, talk with your staff about the Medical Foods and Formulas Access Act. You can reach out to the leads to sign on for co-sponsorship. The QR code there goes to nutritionequity.org, which is the coalition website that represents all of those organizations supporting the bill. There are stories there, state by state, condition by condition, to really understand the impact, the personal impact of medical nutrition and the lack of it. So thank you for your time. I'm going to end where I began, with my daughter as an advocate. That was the beginning of my journey. This is her in Cory Booker's office. I don't know how much protein is in those business cards, but she ate them. In 2020, she advocated remotely from our backyard during COVID, and then 2 years ago, that's her pacing in front of the Reagan office building, working on her speech that she delivered during Rare Disease Week to her legislators. There's a little space there in the rest of the screen. I'm hoping I don't have to fill it with her coming back to ask for this bill to be passed again. So let's just build on the momentum. Thank you for your time, and I'm going to pass it off to Carolyn.
with Carolyn and hear a little bit more from the healthcare professional angle, what types of policy solutions will help support your ability to meet the needs of the rare disease community.
Well, thank you. So I'm Carolyn Applegate, as was mentioned earlier. My day job is I'm a genetic counselor at Hopkins. Today I'm really here on behalf of the National Society of Genetic Counselors, where I'm the current chair of the advocacy committee. And I'd like to thank the Every Life Foundation and all of you for attending today. And also, you will see on my slides if I move them forward, Figure Drinker is NSGC's lobbying partner firm, and so they provided me with some of these slides, so I'd love to thank them. And you can kind of tell my age because I brought paper. But anyway, and sorry, that's a typo there. So first of all, I think a lot of times people say to me, and it's gotten better over the years, but who are genetic counselors and what do you do? And so for those of you who aren't familiar with us, we have master's degree training. What I love about my profession is that we combine both the scientific kind of molecular biology with medicine and with psychosocial counseling skills and kind of bring those all together to try to help patients understand what their risks are, what they can do with that information in terms of treatment, diagnostics, as well as what does this mean for my family member. I think it's one of the most basic human things that all of us think about. Am I going to have what my grandmother had? Am I going to have what my dad has? You know, it's just something that we've all thought about throughout our entire lives from basically the second you could think about things. And so our job is to make sure that people understand what we do know medically can be inherited and not, and make sure that people get the right testing, particularly as we're seeing more and more rare disease treatments becoming available. That lets us, kind of has brought about some hope to patients so that they can now just not know the information, but they can actually act on it and get the appropriate treatment and therapy. And genetic counselors are very trained in rare diseases. 80% of genetic disease rare diseases have a genetic basis, and so we're trained on both the medical and psychosocial needs of patients and families with rare diseases. And historically, and I will hear this all the time, people say, well, aren't you just prenatal and pediatrics? And in my experience, I've been at Hopkins for almost 20 years, and I consider myself a peds genetic counselor, even though I'm about to tell you, most of the time we see adults. So when I started, we had about 30% of our patients were adult patients. And now, about 20 years later, 70% of our patients are adult patients. And there's three main reasons I can come up with for that. One is that these rare childhood onset conditions, these patients, especially our metabolic patients with formula, are living into adulthood and living into, age 50, 60 even. We actually have some 70 and 80-year-olds when I think about it. But so one thing is just people are living longer. The other big thing is that people are being diagnosed. So we used to think that if you had a genetic condition, you were born with this predisposition, that you had to have it at birth. And of course, I think you all probably know this at this point, but even things like Parkinson's disease, dementia, later onset cancers, we now know the genetic basis to those. So that's really been in the last 10 years, and so we're really seeing this shift to our genetics clinics being filled with the adult population. The other thing about that is, I will say in our own specialty practice, we've moved the genetic counselors to work mainly with specialists in other disciplines, so the oncologists, the neurologists, the ophthalmologists, because many of the adult onset conditions are a single organ system, and so the specialists are really managing and diagnosing those, and then we save our medical geneticist colleagues for the pediatric patients or the patients that need that multi-system management, and then referring out to the specialists as needed. So, sorry. Slides. Okay. So as I said, we've had this increasing demand for services for adults and Medicare beneficiaries, but the Medicare program actually does not recognize genetic counselors as providers and therefore does not reimburse genetic counselors for our services. And so this results in Medicare beneficiaries having a significant barrier to accessing genetic services. But it really, as many of you will know, impacts all patients, especially those with rare disease, because CMS typically sets the baseline for all insurers and coverage policies, and so that has an effect on everyone. And so without having an established reimbursement baseline, the other problem is that community hospitals and organizations can't afford to hire genetic counselors. You can't make that business plan to figure out how you're going to afford this. And so most genetic counselors, myself included, are concentrated in academic medical centers in major cities. And this means that we have patients traveling across the country sometimes, but even from, I'm in Maryland, obviously, Western Maryland, the Eastern Shore, crossing the Bay Bridge during the summer, for those of you who are local, coming just to see us when we could be doing telehealth. And so that is one, that we can get them covered, and two, to get telehealth. So the Access to Genetic Counselor Services Act, or HR 6280, or Senate Bill 3607, seeks to fix this by amending the Social Security Act to, one, recognize genetic counselors as providers and allow for direct reimbursement. It also will allow for telemedicine rather than patients having to travel to the big cities. So one of the other things is, why do we need genetic counselors providing genetic counseling other than it's in the name? But one of the reasons is that it does help reduce healthcare costs. This was data I took from the NIH Genetic Test Registry just the other day. There's almost 65,000 genetic tests on the market, and genetic counselors are key to making sure that the right patient gets the right test at the right time, and that helps, one, make sure that they get the right diagnosis and treatment, but also it can reduce costs to make sure that we're getting the right test for that patient. And in particular, I will say, and I can tell a whole story on this, but this is an area, genetic testing in particular is an area where we see a lot of Medicaid fraud. And so billions of dollars have been lost when genetic counselors are not involved in this process because other people, there's no kind of regulation to avoid those Medicare fraud issues. And so the bill, I would like to thank, like everyone else's, I noticed, it's bipartisan and bicameral, and I'd like to support our leads, Representative Adrian Smith and Kathy Castor, as well as Senators John Barrasso and Peter Welsh. And so my ask for you today, like many of my colleagues here, is to co-sponsor this bill, and I'm happy to take any information. I'm happy to talk to anybody if you have questions about that. We have over 300 organizations that support our bill, as well as 500 individual providers across all different medical physicians, physician assistants, and nurse practitioners. And I want to point out that we also cover pharmaceutical companies, we have support from laboratories, we have support from major academic centers and hospitals, and many of our support groups that are here today. And so it really is, a lot of people are supportive of this. I wanted to grab a little bit of data from our institution about telehealth. And so prior to the pandemic, our organization, we had basically no telehealth. We had one mini telehealth clinic that was based on a grant. But then with the pandemic, you can see here that the Medicare beneficiaries, it's the yellow line there, were actually using telehealth at least the same, if not more, than our general population. And for genetic counseling, we actually had 90% of our visits for both Medicare and everybody else were telehealth visits during the pandemic. And data from the CMS telemedicine trends report showed that 1 in 4 Medicare beneficiaries had at least one telehealth visit in 2024. And you'll see this decline that we've had over the years, and some of that is related to just providers preferring certain doctors and wanting to make sure that they can actually do a physical exam on the patients. But a big part of this is actually the instability with knowing when the telemedicine waivers are going to end. And so that brings me to my second request, and that is that Congress makes telehealth a permanent Medicare benefit. So continuing to extend the waivers is disruptive. It leads to institutions pushing for more in-person visits and reducing the number of telemedicine slots. And so if we really want healthcare to be affordable for all patients, particularly those with rare disease, where the only provider familiar with that condition can be hours or states away, we need to ensure that telehealth is a permanent option to provide that care. So with that, I will end and say thank you. And I think we're moving to questions, right? Okay.
Okay, well, thanks so much to our really expert panelists. I think you heard from them about bipartisan, bicameral solutions that not only improve the health and well-being of rare disease patients, but are smart economic policy as well, and are broadly supported by our greater rare disease community. Behind each of these asks, there are countless stories of patients and caregivers in your states that we can connect you with to learn more, and certainly connect with the experts here today, who, those patients really need your help in bringing these bipartisan solutions to the forefront and making sure that they can have the space and the ability to move through Congress because they are such practical, common sense solutions. So we have just a few minutes left today in our time. I want to ask a couple questions to dig in a little bit more. And I think we'll start with Maynard and Shannon. And Maynard, if patients with SMA lose access to the home and community-based services and that paid family caregiving they depend on, what are their alternatives? What happens with these patients?
Thanks for that question. So a couple of years ago, we put together a report, and it was called Stuck Inside, a national report on caregiving. The reason we call it Stuck Inside is because one of our adults with SMA said they would literally be stuck inside their home, in their bed, if they didn't have access to caregiving. It's literally what they need to do to be able to function and to be able to do the great things that they do within their community and within their family. But the reality is they would have to immediately turn to their family, which is just not sustainable. The largest segment of the SMA population are adults, and a lot of the adults have aging parents. It's just not a sustainable system. The other thing is that they would no longer be able to live independently. We've got 35-year-old adults with SMA who are living with their parents because they do not receive the caregiving hour they need to live independently from their Medicaid agency. And so, you all are adults. I'm not sure how many of you live with your parents, nothing wrong with that. But some of our folks want to be living on their own. They just can't actually do it because of no access to caregiving. Ultimately, it results in healthcare results and risks because there is really no backup system. Caregiving, if you pay it out of pocket, is very costly, and it's not really an option for most. And then ultimately, they would then have to go into a nursing home or a long-term care setting, which is not something that's good for them, for their personal health, or their mental well-being, and it's certainly not good for our the ecosystem of healthcare in general. So not a really great option, to be honest with you, which is why we really ask you to preserve, protect, and strengthen Medicaid.
Great. Thanks, Maynard. And Shannon, can you talk a little bit about how the costs of caregivers affect families across generations? As we heard from Maynard, sometimes it puts families in difficult spaces as they age.
Yes, I think it's important. It's important to recognize that family caregiving is so incredibly common in the United States. I think the latest data has it up to 63 million caregivers in the United States caring for a loved one with a health condition or a disability, and you see all sorts of dynamics from parents caring for children with disabilities or adults with disabilities, or children who are helping their parents as they cope with the diagnosis of the neuromuscular disease space. Regardless of the caregiving dynamic, the costs are significant, and in the neuromuscular field where there's so few therapies and treatments available, these are costs, as Maynard said, that are really borne over a lifetime and accumulate for families. So it really depends on the family and the specific caregiving situation.
Thanks, Shannon. I want to turn to Jason and ask if you can share a little bit about why the Safe Step Act has faced challenges in getting across the finish line in Congress, and what you want people in the room to know, what we need them to do, and maybe what role the states have been playing in the conversation as well.
Sure. So what challenges has it faced? I would say it's just faced consistent surprise pressures that have taken it out of the conversation, I guess is the best way to put it. It was really close last year as that DVM reform bill was going through. I guess I would say it's not so much that the bill has faced any problems, it's just the environment around it. So, and within the states, look, we constantly are asking governor's offices, delegations to talk to their federal reps, especially if folks haven't supported the bill at large, just knowing that everyone back home obviously has already made that decision. But I think it's a really strong partnership to be able to work sort of the state side of it, gather support that way, and then work your way up into the federal leaders, because it takes care of both of the sort of problems related to insurance that are necessary.
Before, I have a couple more questions, but I want to make sure if there are questions in the room. No? Okay. Well, if you think of any, let us know. But we'll turn to Sarah and ask, you mentioned the federal health employee benefits or the TRICARE coverage achievements. Have you heard from patients or families that have gained access because of these changes, and what would you want members of Congress to know?
Thank you. Yeah, I have heard from them. Even last night I got some messages. I think, and it's surprising but not surprising, in the federal health benefits area, they said, well, it's great to have formula coverage because now I can spend all my time advocating for medical food coverage. Frees up some time for another battle. And interestingly, we all know this, that when we pass legislation, it doesn't mean that the next day it works. And we're looking at that, TRICARE implementation starting in 2017. And they're still working out the kinks, but I think it has given a lot of people more freedom. And it was interesting because I had one person say that the example I gave of people moving from state to state for medical foods coverage, they said, well, as a military family, we can't choose what state we live in. And so that has at least freed us and given us that coverage that obviously we don't want people to have to move from state to state, but those families particularly were caught in this situation where they didn't have the freedom to uproot their lives all the time for medical nutrition. And so I think there is a lot of sort of relief and appreciation for that, but also recognition that they're a special group and they want to see that expanded to the rest of the community. We don't have from within DOD any information. I think patients and providers for medical nutrition equity would like to understand what the implementation of that TRICARE coverage has meant for those families. Claims data would be useful. So just anyone out there who wants to talk to me about that, I'm happy to connect.
Wonderful. And one last question for you. If you can touch on a little bit more the role of telehealth particularly in rural areas for rare disease patients, that would be helpful.
Yeah. I'm going to go a little broader. But one of the things to think about is with rare disease, there's often only one physician, one person, or one or two individuals in the country, if not the world, who are familiar with that condition and have seen multiple patients with it. And so telehealth becomes, so for instance, at our institution, we get requests from patients all the time that want to be seen. For patients that have private insurance, they drive. They will arrange their family vacation to come to Baltimore, come to DC, in order to come see our providers as part of that family vacation. And we could be doing telehealth, but there's basically two major barriers. The first one is licensing. So licensing is on the state level, and so even though there are compacts, you still have to pay all of the fees. And so for us, as I'm saying us, but for our physicians, for the genetic counselors, that means paying that fee in every single state and going through the process in all of those states, which is really just not feasible for any of us. So I would love to see more work around how to deal with the licensing issues. The other big issue is for our Medicaid patients. We have to get a single case agreement if we're going to see an out-of-state Medicaid patient. Between the out-of-state Medicaids and our institution, that's generally a no-go when we're talking about something that's non-surgical. And so that is another big area where I'd really like to see, at least for specialty care, for high acuity or really rare diseases, I'd like to be able to see some reciprocity or some exemptions. And Hopkins has been working on two major initiatives related to that, and I'm happy to connect with people.
Great. Well, I think as we conclude here, before we conclude by thanking our briefing sponsors, which make this event possible, and we are very grateful for also our Rare Hub partners, many of which you are hearing from today. I want to just emphasize again that the access issues you heard about today are complex. They are just a sampling of the issues facing the rare disease community, but please, again, know that these solutions are there. They are bipartisan. They are widely supported in the community, and they are ready for action. So we look forward to working with all of you to help make that action possible as we enter the second half of the year here and the remaining months of Congress. And I encourage you to talk to the experts on the panel after the briefing and to reach out and follow up to get connected with them. They're the patients in your state and the data that's really driving this policy forward as well. So with that, thank you so much. Thank you guys.